Dr. Buchanan got her undergraduate degree in biology from Carson Newman College, now Carson Newman University, got her medical degree from East Tennessee State University, did her residency at the University of North Dakota in its family practice residency program. She joined the Knox County Health Department in 2004. She was appointed director of the health department in 2009, and she still retains her role as public health officer as well. Under her leadership, the Knox County Health Department has received a grant from the Robert Wood Johnson Foundation, part of their Healthy Kids, Healthy Communities grant. She has formed an alliance with the University of Tennessee, making the Knox County Health Department an academic health department, with students being able to learn under her guidance and her officials' guidance. And the Knox County Health Department under Dr. Buchanan became the first health department in the state to be accredited by the Public Health Accreditation Board. So we are very happy to welcome Dr. Martha Buchanan to the UT Science Forum today, talking about pandemic planning versus reality.
Thank you, and thank you, Dr. Littman, and thank you for the invitation. I appreciate the opportunity to be here today and share some of our experiences of COVID-19 and responding to a pandemic. And you know, my title is, I'll pull up my presentation here in a moment. My title is Planning versus Reality, and COVID-19, this got real, and it has really been a very different experience than what any of us expected. And I'll talk a little bit about our history and how we planned, how public health is planned, and how we got here and how things are going. So I'm happy to answer questions during or after the presentation, so whichever works best for you all. So just a little bit about us here at Knox County Health Department. We are a locally funded health department. So most of our funding comes from local tax dollars. And so we have about a budget of about $22 million. About 18 million of that comes from the locally, and some of the rest of that comes from federal and state funding. We have about 270 employees, and they're kind of split between clinical, non-clinical, and about a 40% clinical, 60% non-clinical. And those non-clinical folks do everything from regulation to outbreak investigation, education and prevention in the community. And our clinical folks do everything from providing WIC services to immunizations and STD treatment and TB treatment. Currently, probably about 80% of our staff are in some way engaged in our COVID-19 response. That's how all-encompassing this response has been for us and for everybody across the country in public health. So a lot of our other efforts around prevention, around reducing opiate addiction, around reducing opiate overdose deaths, around obesity are all on hold right now. We're working hard to get back to those, but as you can imagine, with the COVID numbers continuing to be significant in our community, we haven't accomplished that yet, but we're working toward that. So just a little bit about public health preparedness and kind of how public health got into emergency preparedness. Back in 2001, after 9/11, there was funding dedicated and set aside for public health emergency preparedness. And that really gave us a seat at the table that we hadn't had with our local emergency planning committees. So we were at the table with other first responders, planning for eventual disasters and considering what would be our role. And actually, we're given some very specific roles in those responses. Anybody who's familiar with emergency preparedness, emergency planning, everybody has their roles and kind of their lane that they stay in. Through that, we also created what we call healthcare coalitions. And those healthcare coalitions are a network of mostly hospitals and other providers that meet regularly together, exercise regularly together, and I don't mean that they go running, but they have exercises for planning purposes on a regular basis, and agree how they're going to share, sometimes how they're going to share resources. During COVID-19, it's been a way for hospitals and others to get the supplies that they need, such as PPE and testing supplies. So it's been very important. And having those relationships has proven to be very important in our response. We knew it would be, it always is. And again, talk about our exercises. We've exercised everything from real-time, all hands on deck exercises where people have roles to play and we use fake blood and stuff like that, to tabletop exercises. So we learned from our emergency response partners that exercising and planning and practicing helps when things really happen. And that's been so true. We have those relationships and they're well established, and we're able to call on those folks when we need to. And the other thing that we all had to do is we all had to come up with all hazards plans and continuity of operations plan. We are currently in our continuity of operations plan still. So what that means is we are operating under incident command. So you might not be reporting to your regular supervisor. You might be reporting to somebody else for the COVID response who's over that division. And as a result of being in our continuity of operations plan, we are not operating, we're not offering a full slate of services, although we are offering many services. We're still offering family planning. We're still testing and treating for TB and STDs. And we're also actually virtually providing WIC services for lots of moms and babies out there. So I've been at the health department for 16 years, and in that time we have responded, and I'm probably going to miss some stuff, but to the big things that y'all would have heard about: anthrax, H1N1, chikungunya, Ebola, Zika, and of course now COVID-19. And you may be thinking, well, we didn't have any Zika or Ebola in Knox County, but we didn't have any Ebola. We did have some Zika, but we quietly responded to those to help protect our community and reduce risk. So how is COVID-19 different than all those things I just listed? When we think about anthrax, we never actually had any cases of anthrax in Knox County. We had a few scares. I remember we shut down a local emergency room one time because there was some mysterious white powder left in an exam room. That was during kind of the hype of anthrax. We also learned to work with our post office partners and what if somebody tried to mail some anthrax, how do we respond to that? During H1N1, we had local cases, and we actually kind of started off doing similar to what we're doing with COVID-19, doing contact case monitoring and contact investigation, but pretty quickly moved to a more routine method of surveillance when we had community spread, and didn't continue this level of, that's another big thing that's different about COVID, this level of case investigation and contact tracing is higher than normal for when we have community-wide spread. Ebola, we monitored travelers who had been to Ebola hotspots. Obviously, we never had any actually Ebola acquired in the United States, and certainly had no cases here, not even imported cases. Zika, we did actually, believe it or not, have a few cases of Zika here in Knox County. They were folks who had traveled somewhere where Zika was being spread easily and came home, and we were required to monitor them and educate them. And we asked them to stay home and stay inside for 7 days. And we had really good cooperation with that. What we wanted to do in doing that is prevent local spread. We didn't want somebody with Zika to get bitten by a mosquito here and then go bite somebody else and transmit Zika to that person. And we were successful in that. Part of that is because of the type of mosquitoes. Part of it was also we had really good cooperation with our cases. Chikungunya, I don't remember if we had any cases of chikungunya. It's another mosquito-borne illness that we did have to monitor some folks who traveled, but again, very limited geographic spread in the United States. But then the big difference, obviously, with COVID is we have ongoing domestic and worldwide transmission and waves of outbreaks, which we typically see in infectious disease, where we have spikes and downturns and spikes and downturns. And sometimes that can be the result of things put in place, and sometimes it's just the result of the natural course of the illness, that it kind of comes and goes. So other ways COVID is different, that have nothing to do with the disease. Well, they do have something to do with the disease itself. The current political and social environment is different. I don't think anybody on this call would say there haven't been some changes in our political and social environment here in the United States. Very much more conservative leaning, much more independent leaning, much more, at least from our perspective, a larger degree of skepticism about the government and government regulation and intervention. The length of this response, I don't think any of us, I don't remember anybody talking about staying in your continuity of operations plan and in full response mode for 6 months. That's a really long time to keep those efforts up. So the community's tired and we're tired, and we all just want to get back to normal, but we can't because COVID's still here. And then the all-encompassing nature of this impact, of the impact of COVID. You know, it's one thing when we deal with a dairy or a restaurant where we have some cases related to that place and maybe we close them down for a little while. It's very different when we're saying, okay, we have this throughout our community and we need to close things down when we don't even have a connection to a case yet, but just to prevent illness. That's a very different approach. And it impacts, and we realize that, it impacts livelihoods and socialization, and psychologically impacts our community. And the other thing about SARS is it's a really efficient virus. It's really easy to catch. All I have to do is stand and have a conversation with you in less than 6 feet from you for more than 15 minutes. That's not too hard to do. I don't even have to be sick to give it to you. You just have to breathe some of those droplets in that you don't even know you're breathing in. It makes you sick, but it doesn't really kill off everybody that gets it, so it can keep being passed on to other people. And actually, you know, it's really easily passed when we humans are at our most vulnerable, like late night at a bar, when we've all been drinking and, you know, maybe just a little more relaxed and everybody's your best friend. That's the perfect place for COVID to be spread. So it's just very efficient and it can easily be passed. And again, doesn't really kill off its hosts. Although people do die from COVID, it's not the majority of cases. So let's talk a little bit about our local COVID response. If you were paying attention and you live here, you knew that, you know that we kind of had a slow start. We had our first case in March and didn't really have a ton of cases coming in regularly. We actually had some days where we had no new cases. That was very early on when testing was limited, and our caseload was slow to start. We did exercise our local public health authority quickly. We looked at Nashville and we looked at Memphis, and we said, you know, when did they put things in place, and look how their cases went up. We wanted to be a step ahead of that in our local response and try to get ahead of the game and put things in place probably before a lot of people thought we needed to, in order to reduce caseload. You know, our caseload stayed low for a while. I mean, our deaths were very low as well, and our hospitalizations. That gave our hospitals time to kind of get together and do more planning and come up with a more solid plan for the reality of COVID and what that means for them. I don't think our public health authority and closing things down can account for all of that, but I do think it did contribute to the slow rise of our cases. But then we also had to start thinking about how do we reopen. That's actually harder than closing things down. Closing things down is kind of easy. You go, let's close things down and where people might transmit this disease. But how do you say, okay, now we still have COVID. We can't wait 2 incubation periods for COVID, which is what we would do in a nursing home. They have a noro outbreak. We're going to say you need 2 incubation periods without a new case, and then you can go back to normal activity. Well, if we did that with COVID, that would be 28 days with no new cases. That's just not reasonable. That's not going to happen. So how do we enable people to reopen safely so that we can stop the devastation to our economy, so that we can start supporting people to get back to regular activity? So we started that early on as well. And then the other thing is that this has been new for our law office to navigate this scope of an outbreak and to be this heavily involved in helping us navigate that. So over time, legal guidance has changed, and we've had to change with that legal guidance as well. Just about everything has changed with COVID, and we've had to change with that as well. So we'll dive right into a little bit of data. This is a very busy slide, and I apologize for that. But what I wanted to try to show is that, so we had a really slow start here back in March and April, and we put our orders in place. This was a weekend, our first weekend, where we had kind of a peak in cases. Little did I know that was just the beginning. So our closure of bars and encouraging people to stay home was quickly changed to the safer at home order, which also closed non-essential businesses, had restaurants move to takeout only, or delivery or pickup, or curbside. And really, really kind of had people go home and stay home, and a lot of people were not going to work. People started working remotely then. And we kind of cruised along for a while. We made some adjustments to that when we said, hey, our cases are looking pretty good. Maybe we can think about reopening some things. And we started doing that. We had a task force that we put together to start planning for that. We had business people there, public health people there, city and county representation, and it started that process of saying, okay, let's try to reopen things slowly. And we very few things reopened. That was a really slow process, but I think that was the right thing to do. And then if you jump on over to phase 2 reopening plan, that's when we allowed more businesses to open. We allowed personal service businesses like salons and other places to open with lots of restrictions. And I'll be honest, the salons have done a great job of making sure people wear masks and making sure that everybody's wearing a mask. If you've had your haircut lately, hopefully you had the same experience I've had, where they're really doing a great job because they want to stay open and they want to serve their clients. But as you can see, as we relax restrictions and relax guidelines, the public let its guard down, and we can see that our cases continued to increase. It was slow and steady, but it continued to increase. And the governor and the state had been doing writing some guidelines called the Tennessee Pledge. As one of the metropolitan health departments, we are allowed to divert from what the governor does. It's actually in one of his executive orders, allows us to be more or less stringent than his executive orders are. We can always be more stringent than state law. We can't be less stringent than state law, because if we were, then people doing what they were doing in Knox County would be breaking state law, so that's not a good idea. So we said, hey, let's follow the Tennessee Pledge. But then we noticed that our cases really started climbing. Back at the end of June, early July, we saw a pretty significant increase. We can also kind of tag some of this to some holidays, Father's Day and other Memorial Day, where we kind of saw peaks after those happened. So the Board of Health, this is one of the legal changes. It went from the health officer, me, having the authority to write these orders, that was determined that the Board of Health should be writing these orders. And so the Board of Health put in place the mask mandate. And so that went into effect right around the 4th of July. And what we know about when we put things in place, it's going to take us 3 to 4 weeks to really see the impact of those things being put in place. So it's not immediate, because one thing, you have to have the people who've been exposed to get sick and get better in order to see that start dropping. And people have to adopt the guideline. It was a mandate. We're not citing people for that. People aren't getting tickets. People aren't going to jail. None of those things are happening, but people putting it as a mandate helped the businesses out. Businesses told us that it's a lot easier to say, the health department or the Board of Health wants you to wear a mask than I want you to wear a mask. So we were fine with that, make us the bad guys, and get some compliance with mask wearing was okay with us. But you can really see that over that time, we did see a decrease. If we had a trend line there, that trend line would be going down after the mask mandate was put in place. And then the Board of Health started anticipating the possibility of UT coming back and Knox County schools starting again. and decided to put some more restrictions in place, reducing what we've learned from Dr. Birx with the White House COVID Task Force is that in other places where cases have gone up, reducing alcohol sales later at night helps reduce case counts. So we put some restrictions on bars and made some small edits to those. And, you know, our cases kind of continued to go down, but then UT came back and Knox County Schools started back, and we saw a pretty significant increase in cases, particularly among the 11 to 30-year-olds. So really seeing those increasing cases as we anticipated with the restart of both UT and Knox County Schools. Currently, we still have a mask mandate in place. We also have a mandate reducing social gatherings. The fewer people you have in a place, the fewer people that can be exposed, and the more it's easier to social distance. So that helps. That's also been shown to be effective. And consumption of alcohol and sale of alcohol is supposed to stop in Knox County at 11 p.m. Obviously, that's not in your private home, but that's out in restaurants and bars. Anecdotally, we know that some folks, compliance with that is mixed. How about that? I'll just say that. Trying to move this so I can see. So if you look at the trend line from here at our max and come down through here and see that, you know, it looks like our cases are trending down. I will tell you our case positivity rate, our test positivity rate has trended down a little bit in the past couple of weeks. Our cases per 100,000 right now are at, I'm looking at,
I'll get it for you. I'll give you that.
they're actually, we're actually higher than Nashville and Memphis right now for that. But before you say, oh, look, all these regulations work, let's look at the next slide. So the green line is testing per day. And it's kind of our trend line for it's not the numbers of testing per day, it's kind of a trend line for testing per day. And if you go over here and look, so we had pretty good testing going on back here, but we can see that we're kind of trending down in our testing. And we're hearing this from our partners, we know this from our testing that we're doing. Our lines are shorter, we're testing fewer people, and we're actually being told by UT students, excuse me, that they're avoiding being tested because they don't want to be isolated and they don't want to be quarantined. And we also know from schools and parents that a lot of athletes are avoiding testing because they don't want to be the reason their team doesn't get to play this Friday or whenever. So we are very concerned that our testing numbers are going down, but we're seeing an increase in our hospitalizations. We have the most hospitalizations we've had since this pandemic began. And that really doesn't go with the picture of cases that you see here. So we're very concerned that our burden of disease in our community is much higher than you can see on this graph. And we don't have a good solution for that because people are really avoiding getting tested.
We're currently at 19.9 cases per 100,000. That was as of the 8th for the last 7 days.
And that's the voice you hear is Charity Menifee, our Director of Communicable and Environmental Disease and Emergency Preparedness. She's our main lead here in the health department for this response. So, and that is higher than Memphis and Nashville, about 19 per 100,000 cases. So that's kind of where we are. It's kind of some of the things that we've done. So I'm going to talk a little bit about some of our challenges. One of our challenges, is the ever-changing guidance. You know, one of the challenges is that anytime you have a pandemic, it's a new disease. And so you learn about the disease as time goes by. You learn from what other people saw. You learn from those things. And you have to make changes or you're really doing a disservice to your community if you learn new things and you don't change what you're doing. But that does breed some mistrust and some uncertainty and confusion. I talked a little bit about the legal challenges we've had and the changes in that. The politicization of COVID-19 has been a real surprise to myself and my staff. I think, you know, we started into this. We're like, hey, we know how to do outbreaks. We know how to do quarantine and isolation and contact tracing. We do that all the time. We can handle this. But then there was all the political stuff and the social and economic, and so quickly became kind of obvious that there were pressures and other things that we do consider, but not to the level we have to consider them with COVID-19. And, you know, where if you wear a mask, you're left leaning. If you don't wear a mask, you're right leaning. And it's just that public health guidance became a partisan issue, and it really isn't a partisan issue. It's really just public health guidance. And I've spoken a little bit about the length of response. You know, again, everybody's just ready for this to be over. It will be eventually. COVID-19 will be with us. Hopefully we'll have a vaccine. It will be one of the many things we all get vaccinated for every year once the vaccine is developed. Some of our lessons learned, you know, science is important, and it's what we use to provide guidance. But I think we in the academic and science community have to learn to language it better and more correctly for the understanding of the general public. I think that's a real challenge for the general public. You know, we get so comfortable with the language that we use every day, and it's a new language for our community, and being sensitive to that will be something that we've learned a lot about and try to do all the time. Learning as we go is something that we all do, but it's not always perceived as being positive. It's frequently perceived as being, you didn't know what you're talking about in the first place. Think about masks. I mean, early on, it was like, no, don't wear a mask. Only medical people need to wear a mask. And now it's like, oh yeah, everybody should wear a mask when they're out in public. So, and it's been kind of up and down like that with a lot of things. The other thing is, in a perfect world, we would wait for all these reports and data and all this stuff to come back, and we know exactly this is going to work. If we do it this way, it's going to work because we have 25 papers that tell us that. We can't wait. Our community can't wait. We can't wait for the data to make all the decisions. And sometimes we just have to look and say, hey, they did that. It worked for them. Let's try that. And that's not always, it's not always perfect. It doesn't always work that way. But that's something that we have to be able to be willing to do. We have to be willing to take those chances and say, we're going to put this in place and see how it does and see how it works. And, you know, we always knew this, but it's very evident now that public health decisions, public health does not happen in a bubble and alone. We know that the decisions make impact our community, but with COVID, it's really highlighted how much of an impact those have on our community. And then, so just to talk real quickly a little bit about our strengths that I've really seen through all of this. You know, we're really good at isolation, quarantine, case investigations, contact tracing. Under Tennessee code, we have a lot of authority to do the things that we do. We are used to using data to make decisions. We're willing to change and learn. And we do consider the impact of the disaster and the guidance that we provide on the community all the time. You know, if we're going to close a business, we consider, you know, how can we do the least impact on the people that work there and still protect the public? How can we do that? In this situation, we kind of, you know, we needed to do something more drastic. And for us, it's never been protect health or protect the economy. We try to consider doing both. But sometimes you really have to make a decision that you know is going to really hurt the economy to protect health, because also, if we don't protect health, the impact on the economy could be even greater. You have lost productivity. You have people you have more deaths, so you have people who die who would have otherwise been productive and contributing to the economy. And you also really could devastate your medical community and your medical infrastructure, which is, again, another big economic impact for the community as well. Some of our challenges, communicating clearly. We could just get comfortable with our language and trying to stay away from our jargon that we like to use all the time. Underestimating, at least for me, this one's probably maybe not everybody, underestimating the politicization of COVID. I really just had no idea how politically charged all of this was going to become. And, you know, I think our guidance is really neither right or left leaning, although we frequently are accused of being very left leaning. Right now, I'd tell you that the people on the far left aren't happy with us, and the people on the right aren't happy with us either. So I think we've struck a nice middle ground. People on the left think we should do more. People on the right think we should do less. And so I think we're in a good place with that. Enforcement's been a real challenge. It's some of the things we put in place are hard to enforce, and getting cooperation throughout the justice system has been challenging. Staffing's been a real challenge for us. We've been in our continuity of operations plan working 7 days a week for 6 months, 7 months now. We've been bringing staff on, but there's a lot of training required. Contact investigations or case investigations and contact tracing are nuanced and have some challenges to learn. And just actually having the opportunity to actually practice public health. There have been all these distractions, the political stuff, the economic and social stuff, and all those other things that really distract from the doing and practicing the public health have been challenges for us as well. Taking energy away from what we need to be doing to protect our community. So some of the things I think when we going forward, we'll have a big after action about this sometime. I've asked staff to write things down so that they can remember, because I know I wouldn't remember all the things I wanted to say about what we did well and what we didn't do so well. But widening the circle of who's at the table for planning, I think is going to be important moving forward so that we can take some of these things into consideration. Letting go of some assumptions. When we have some isolated cases of something, we run the show. It's our, we keep the mayor's office informed, we keep the public informed as needed, but with something this big, I think there has to be a lot more shared responsibility and decision making. And obviously we want to apply the lessons we learned from COVID and stay flexible. And again, better ways to share best practices real time. One community does this and it works really well, but there's no good way to get that out to the bigger public health community. So how do we do that? And again, we'll stand ready for the next thing, because there will be, as we all know, another emerging infectious disease. I don't think outbreaks such as this are going to be a thing of the past anytime soon. So one thing I found that was interesting when I was researching, getting ready to do this talk, I found something published in the American Journal of Public Health in 1930. The title was Pre-Disaster Preparedness. The author stated, disasters are no longer minor or chance occurrences, but each year they are more widespread, more devastating, and more demanding of harmonious assistance. And I couldn't agree more. The harmonious assistance is really important and has been hard to come by in our COVID response. So that's what I got. I'm happy to open it up for questions, and I have my expert in the room in case you ask questions that stump the chunk.